Yeah, welcome back to online CMA program on this second session on cyanotic heart disease, patent ductus arteriosus. How to approach, how to diagnose, and how to treat. For knowing the PDA, it is very important thing to understand the fetal pathology and the fetal circulation. So the classification is, I have already mentioned in the first class of the ASD. Here the left to right hand example is a PDA. So the commonest one, 5 to 10% of congenital heart disease are PDA. So I'll be dealing this patent ductus arteriosus within 20 minutes of time. So this is a 15-year-old boy who diagnosed PDA very late. By that time, he had developed already the pulmonary artery hypertension and recurrent infection, pneumonia, and look at the lungs. It's fully congested, and it's so sad because of the PDA and failure, intractable heart failure without any medication in a peripheral or a village setup. Dying due to PDA is it is very, very, very sad. Now the diagnosis of PDA is crucial. And patent ductus arteriosus, this is a diagrammatic representation, the connecting the aorta and the PA. And this is the aorta and the PDA connecting to the near orifice of the LPA. So this the orifice will be, PDA orifice will be very near to the LPA orifice. Sometimes it can be in the mid or bifurcation of the PA. The PDA can be arise from the, depends upon the arch, right or left, or from the arch it can develop. So we mainly deal with this left aortic arch and the PDA. So the cardiac embryology I had mentioned. And the first 2 weeks, no heart, no great vessel. And only the pulsation will start, that is 4th week, that means 21 days of time. The cardiac C-tube will develop and slowly will fold it. And then the circulation will start slowly. And this arterial duct arising from the 6th aortic arch. And this is the circulation, if you learn. This is a 3-vessel umbilical cord, 3-vessel from my autopsy. This is the umbilical vein and 2 artery connecting to the branch of the iliac artery, communicating through the umbilical artery to the umbilical cord and to the placenta. And this umbilical vein go behind the liver, and the junction where the ductus, the portion of the umbilical vein joining the caudal vena cava, that is inferior vena cava, that portion is called ductus venosus. And this blood carries highest oxygen. You know, the fetal hemoglobin can carry 130% than the adult hemoglobin. That is an amazing, this highly oxygenated blood passing into RA, then to the LA, not to the RV. Why? Because the IVC valve got created is a flaggy valve, eustachian valve, that will flag the blood from the RA to the LA to the LV, and then it supplies the very vital 2 important organ, the brain and the heart. So the half of the blood will bypass to the ductus, half will go into the liver. Whereas the SVC carry less oxygenated blood going to the RV and to the PA, ductus arteriosus, and lower part of the body, and then return to the placenta. So this is my autopsy specimen. Very clearly I am showing a dilated PA. This is a pathological heart. And otherwise also in the ductus, in the fetal life, PA is bit larger than the AO. Here the ductus also dilated. This is the left LPA, arch of aorta, right arch, and this left subclavian, left common carotid, and innominate right subclavian and right carotid. Very nicely I figure it out, and you need little bit artistic heart when you do the autopsy. And this is the left upper pulmonary vein, left lower pulmonary vein. Clearly, I am showing even the left anterior descending at coronary artery. And the umbilical cord, the ductus venosus, which I said, the portion which is attaching to the inferior vena cava, there you put the cursor, you get a pulse Doppler will give a continuous flow. This is a particular wave pattern. If you see that, it is a ductus venosus. But the portion where you have to put the cursor, look at this turbulence, sun-like area. Yeah, here. Look at this here. There you put the cursor, you get that kind of a Doppler wave you will get. Then the postpartum remodeling, if you look at that ductus venosus area, there that will become ligamentum teres hepatis, and the ductus arteriosus, immediately after cutting off the umbilical cord, the lungs will work and the oxygen will be higher, and PgE2 receptor will be decreased, and PgE2 level also decreases, and that produces constriction of the muscles of the vasa vasorum, and the constriction, and then slowly fibrosis will occur, and then the ligamentum teres will come. This will happen with the physiological closure within 24 hours, and whereas the anatomical closure can become very tight fibrotic band, maybe it can up to 1 year of age. So the medial, the umbilical artery can become superior vesicular medial umbilical ligament, and the fossa ovalis will become closed. So in 1593, Giambattista Carcano described ductus arteriosus in his book as a great vessels of the fetus. 5 to 10% of CHD is PDA, ductus arteriosus from 6th aortic arch. Both the functional and anatomical closure usually attained by 24 to 4 days of time. Sometimes the anatomical closure by 4 to 6 weeks. So you have to wait till 6 or 4 weeks. But once the ductus is diagnosed after 4 days, you have to give a trial of pharmacological therapy, the drugs, either ibuprofen or a paracetamol you have to give. In my study, I did 32 infants with the tame babies with moderate to large PDA. I found that the moderate to large PDA can be the size can be decreased to small to moderate if you give a pharmacological therapy. Most of the time we give only to the preterm. No, you can give a trial, nothing harm. Because if you can reduce to moderate to small, then instead of a device 70,000 rupees, you can reduce to 25,000 for a coil. So that is an important thing. So the ductus arteriosus is arising from the 6th aortic arch, and the right side portion will be regressed. Here you can see the short axis view of the aorta, PA, dilated PA. You can see that PA was dilated. The blue color is a forward flow in the PA, means going away from the probe, and this is towards the probe. So a red or orange color or turbulence within the blue color, it is nothing but ductus arteriosus, a sword-like jet from the LPA side traverse lateral border of the MBA. Indirectly, LV will be dilated and LA will be dilated. A healthy full-time newborn ductus arteriosus generally undergoes functional closure between 24 and 72 hours. That I have already mentioned. How it will close, because the level of oxygen saturation in the blood, arterial oxygen saturation will decreases, and sudden chopping off of the placenta, cut off from the placenta, from the neonatal circulation, and increased pulmonary flow, and prostaglandin E2 will decline, local receptors number, so the constriction will take place. There is a beautiful study of Bennett's and committee. They found that after the fourth day, ductus arteriosus can persist 10% of infants only in 30 to 37 weeks. That means term and near term or late preterm, there is a spontaneous closure is very, very high. Whereas between 25 and 28 weeks, 80% will be open, 90% in 24 weeks. Whereas after 7 days, if you wait without any medication, this 10% in the term baby become 2, 65%, the 80 will become 65, 90 will become 87. So there is no harm in giving pharmacotherapy. Then this percentage will much will come down. Term babies and preterm babies, closure is very, very high after giving the pharmacotherapy. Once the pharmacotherapy, neonatologists are now trained to see the PDA, and they take advice of the pharmacotherapy. Now they themselves are treating, so that nowadays coiling and the device closure is the prevalence is coming down, I feel. What are the complications we see if you are not detecting the PDA? That can be associated with the severe RDS, prolonged need of assisted ventilation, pulmonary hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, renal functional damage, intraventricular hemorrhage, periventricular leukomalacia, cerebral palsy, and lead to further death. So mortality is very high if you are not detecting the PDA. That is very important. Even I teach neonatologists and technicians, or it is not necessary to diagnose PDA by cardiologist. You take this short axis view at the AV valve level, both RPA, LPA, you can see that level. I had showed you a blue color, the yellow color within the blue, then it is nothing but PDA. But still, if you have a doubt because of any pulmonary stenosis or some confusion comes for early members in the career, I say that put a M-mode cursor, the continuous wave Doppler cursor within this LPS side, you get this continuous flow. Both diastolic and systolic flow is filled. So there is a murmur when you do it, murmur when you auscultate. There is a machinery murmur or a tunnel train in a tunnel murmur. Measurement at the two-dimensional view of the ductus in ductal mode, no color flow measurement. So this is look at this. This is the LPA. This is the ductus. So 3 vessel view, and this dimension dual view you take. Never take the color flow measurement, that will be erratic and over measurement. Here you can freeze it, and then the narrowest portion you can measure it. This is a high short axis view. Again, this is a high short axis view also. I say that good for dimension. Even the color flow also you can measure in this view, because the color gain, if it is decreases, and the short axis view very narrow jet, beautifully we can see that is equivalent to two-dimensional measurement. Here the jet is instead of lateral, it is going opposite. That's what I said. Sometimes the ductal opening will go into the central portion or bifurcation of the PA. In that situation, sometimes the jet will go to the opposite side. The high short axis view, again, arch and PA merging, and then for the measurement of the color flow jet, this view is a little more better, and you have to train it. So when to do ductal stenting and BT shunt? That is very important thing. This is our specimen of a case of a right atrial isomerism. Here the PA was very thin and it's like a string. So you can understand that there is no forward flow from the RV to PA, but the flow from the arch to the ductus and to the RPA and LPA to the lungs. So once this ductus closes, then a very dangerous child will die. So immediately if you diagnose, you have to start with the PGE2 and send to the higher center. The important thing is, if you diagnose PA atresia in the fetal life itself, you don't have to take a delivery in the periphery. You can advise that you can go ahead to the tertiary cardiovascular center, where they can do stenting immediately, so that we can save the finance towards the PGE2, the ambulance and traveling. Mother will be in other hospital. So if delivery can be taken place at the tertiary center, that is called in utero transport. So what are the duct dependent lesion? You should understand PA atresia with IVS, TOF with the PA atresia, tricuspid with the PA atresia. Any case with the PA atresia, you should immediately give a note or call the pediatrician or to send a case to a higher cardiovascular thoracic center, where they can do ductal stenting. That is important thing. This is ductal stenting. Case should transport with PGE2 prostaglandin E2 by IV 0.01 to 0.05 microgram per kg per minute. Then only you should send. And they will do within 2 days of life. They will do the stenting, and with the stent the oxygen saturation will improve, and later the child can go ahead for the bidirectional Glenn shunt or staged surgeries. So how to manage PDA? The medical management, as I said, the indomethacin, that was a gold standard for pharmacological treatment over the past 40 years with a high closure rate. So that can incidence of severe intraventricular hemorrhage, pulmonary hemorrhage, and early treatment, but without improvement in long-term outcomes and with a risk of renal toxicity. The indomethacin will act on the COX-1, and the ibuprofen will act on the COX-2. Acetaminophen was discovered equally good as the ibuprofen to effectively close the PDA without much side effects, and I give only oral, not IV, and without even with the oral medication, the around 95% successful rate I had seen. Very rarely not closing. Such occasion I give a second trial also. In that another 1 or 2% may close also. So 15 kg per body weight per dose 3 times daily into 3 days. Oral dose is sufficient as a pharmacological treatment. So the management of heart failure also important. When you see an X-ray, huge cardiomegaly, when the child comes for a echocardiography, we are not merely echo technician. Doctor should look at what is happening at the respiratory rate. It is very fast, even 60-70 per minute. And with the X-ray, immediately you can diagnose that this is nothing but a heart failure with a heart murmur. So the continuous murmur you heard, and then you diagnose. LV will be dilated, sometimes globular LV, dilated LA, dilated PA, increased blue color going towards the roof of the left atrium. That is the increased pulmonary venous return. That itself indicates the left to right shunt is very high. The pulmonary artery hypertension also. Such occasion, please write furosemide 1 to 2 milligram per kg body weight per day in 2 divided doses. Dixin 5 to 7 mics per kg body weight per day in 2 divided doses, 5 by 7 days in a week. If the failure is not controlled by after 2 weeks of therapy, I used to put enalapril or the AC inhibitor 0.05 microgram, the milligram. per kg body weight in 2 divided doses. So when to refer for intervention? For every 3 to 5 months, decongestive measures with small to moderate size PDA. Once congestive heart failure control, send for a device closure. For coil, 6 to 8 months. Preferably, I prefer more than 7 to 9 kg will be ideal by 6 to 9 months of time. Even you can wait till 2 years of age if child is hemodynamically stable. When to refer for surgery? Age concerned, large PDA in failure to thrive with recurrent respiratory infection. Ligation is by closed heart surgery. This is the intervention in the cath lab. Coil device closure. PDA size below 3 mm can be closed with a detachable coil closure. This is the coil. 1.5 circle will be in the PA, and then pull it. Then rest of the coil will be packed, and I used to do by retrograde fashion. But a tiny baby is better. We prefer the antegrade, that means through the femoral vein, so that the femoral artery will be safer and cannot be damaged. And more than 3 mm size PDA device will be better, preferably antegrade in smaller children. The pharmacological treatment I already mentioned. The mechanism you should understand. The ductus arteriosus muscular wall constriction through hypoxia of the ductal vasa vasorum and consequent local angiogenesis, formation of intimal tissue, apoptosis. In conjunction with the platelet recruitment and activation lead to process of obstruction and fibrosis. As a result, anatomical ductal closure, most often anatomical closure by 1 year of time. The first line therapy, always we prefer non-steroidal anti-inflammatory drugs, that is preventing the conversion of arachidonic acid into prostaglandin via cycloogenase COX inhibition in both existing isoform COX-1 and COX-2. That's what I said. The indomethacin will act through COX-1, ibuprofen will through COX-2. The COX-2 action, the constriction of the artery will be little bit lesser, so that the renal damage will be lesser. So this is a finger-like PDA, and this is type A PDA, and the coil closure. Through the antegrade, we give a contrast injection, the arch angiogram. Then immediately the contrast will fill in the PA. Normally, if the ductus is not there, the PA won't fill. The PA is filling, that means ductus is there. So this is a good size ambula to accommodate all the coil within the size of the ambula. So this is a coil closure. This is the device closure. PDA size more than 3 mm, above 6 to 8 months of age, preferably 6 kg onwards. Antegrade method to avoid artery damage in smaller age group. Take home message is diagnosing PDA in preterm and neonate is crucial. Detection is heart failure by both clinical and echocardiographically is essential for early treatment. Preferred medication for pharmacological treatment is oral or IV paracetamol. Surgical closure is ideal in large PDA with failure in first 2 months of age. Hemodynamically stable patient for intervention. Thank you once again.